Hey all, so today we will discuss about ameloblastoma, which is the second most common neoplasm, and the first one is odontoma, as we all know. So ameloblastoma is made up of two terms, that is amel and blastos, where amel stands for enamel and blastos simply means germ. So it is a true neoplasm of enamel organ type of tissue, which does not undergo differentiation to the point of enamel formation. So no enamel is formed in such type of neoplasm basically. Earlier, the term edmentinoma was given by molasses, but edmentinoma basically means something hard or hard tissue is formed. But as we know that no enamel or no such hard tissue is formed in such type of neoplasm, later on Churchill has given a term that is ameloblastoma, which simply means a true neoplasm of enamel organ type of tissue. Now, Robinson has also described this neoplasm. So, it is usually unicentric. It means that there is only single center of origin. Then secondly, it is non-functional because it is having no function. It can be intermittent in growth. Anatomically, it is benign. It means it is not malignant and clinically persistent. So, this whole terms can be learnt with the help of a mnemonic, that is UNIAC. UNIAC. U stands for usually unicentric, N for non-functional, I for intermittent in growth, A for anatomically benign, and C for clinically persistent. I hope this is clear. Now, World Health Organization has also defined ameloblastoma as a benign. So, benign basically means it is not malignant but locally aggressive tumor. So, basically, it will spread really fast in whichever part it is present. Suppose it is affecting any jaw, mandible is affected. So, it will affect mandible really fast. It will spread in that area really soon, but it won't affect any other part of the body with a high tendency to recur, consisting of proliferating odontogenic epithelium. Odontogenic means something that is related to tooth germ formation or tooth formation, lying in a fibrous stroma. Stroma is connective tissue. So this definition was given by WHO, which states that ameloblastoma is a benign but locally aggressive with a high tendency to recur, consisting of proliferating odontogenic epithelium lying in a fibrous stroma. The pathogenesis of ameloblastoma. So ameloblastoma can be arised from the odontogenic epithelium. So firstly, what is odontogenic epithelium? The epithelium that is giving rise to the tooth structure basically. So its remnants can cause or give rise to the ameloblastoma. So the first point is cell rest of the dental organ. So the remnants of the Hertwig's epithelial root sheath, which is also known as epithelial rest of molasses, or the remnants of the dental lamina, which is known as cell rest of series, may develop into ameloblastoma later on. Second point is epithelium of the odontogenic cyst. So the epithelium of some of the cysts, such as dentigerous cyst or the odontomas, can convert into the ameloblastoma. Now, as we know that ameloblastoma is basically a neoplasm of enamel organ type of tissue. So any disturbance in the developing enamel organ can give rise to ameloblastoma. The fourth point is basal cells of the surface epithelium. So the cells of the surface epithelium can also give rise to ameloblastoma. Now the heterotopic epithelium, the epithelium which is present at abnormal place. So this heterotopic epithelium in other parts of the body, especially the pituitary gland, can also give rise to ameloblastoma. This is special entity which is known as pituitary ameloblastoma. We will discuss later on. Now the clinical features of ameloblastoma. So ameloblastoma has a wide range of occurrence. So the ages that is most commonly affected is in between 10 years to 90 years, but mostly it is seen in between 20 to 60 years. Males and females are equally affected, so there is no significant sex predilection. The Asian population is more commonly affected than any other racial group. Mandible is more commonly affected than the maxilla. So around 80% of cases are seen in the mandible. And in mandible too, the molar angle ramus area is more commonly affected than the premolar and anterior region. Anterior region. You can say the molar angle ramus area is 3 times more affected. Correct. Now in Asians have fewer tumors involving ramus than do whites or blacks. And in blacks also, there is increased frequency of tumors in the anterior mandible. Now the ameloblastoma can be central or peripheral. So the central ameloblastoma is also known as intraosseous, which means that it is affecting the bone only. If the lesion is present in the bone, then the ameloblastoma is known as intraosseous or central ameloblastoma. So it is slow growing, painless, bony, hard swelling resulting in facial asymmetry. So facial asymmetry can be seen in such type of ameloblastoma. If the lesion is large, it will cause mobile teeth, pain, and paresthesia. Paresthesia means either loss of sensation or abnormal sensations, you can say more precisely. It is locally invasive. It can infiltrate medullary spaces and erosion of cortical bone can be seen. As we know that in a bone, there is outer cortex and inner medulla. So the medullary space is basically infiltrated, whereas the outer cortex is eroded in intraosseous ameloblastoma. Now the peripheral or extraosseous ameloblastoma, the ameloblastoma that is affecting the gingiva or the mucosa basically. It is not affecting the bone. So this is peripheral or extraosseous ameloblastoma. Histologically, it resembles the central ameloblastoma only, but and may be reported under basal cell carcinoma of the gingiva. It originates from the surface epithelium remnants of dental lamina, as we have seen in the intraosseous ameloblastoma, the same pathogenesis. Now, the pluripotent cells of the basal cells of the mucosal epithelium or the pluripotent cells of the minor salivary gland. What is pluripotent cells? The cells that can give rise to many other type of tissues basically. Now, what are the clinical features of peripheral ameloblastoma? So, the ameloblastoma can occur in the age between 30 to 50 years. There is male predilection. Males are more commonly affected than the females. Mandible is more commonly affected than the maxilla. The lesions are in the form of the nodules present on the gingiva. The nodules are of 3 mm to 2 centimeter in size or diameter basically. Now the histological features and electron microscopic appearance of the extraosseous ameloblastoma, it is similar to the intraosseous ameloblastoma. So remember this, they are totally similar, just histologically and electron microscopically, but the affected areas are different. In intraosseous, it is affecting the bone, but in extraosseous, it is affecting the gingiva and the alveolar mucosa. This much you have to remember. The electron microscopic appearance of the extraosseous is also similar to the cutaneous basal cell carcinoma. Now the extraosseous ameloblastoma, which is affecting the soft tissues basically, is relatively innocuous. It means it is less harmful than the intraosseous ameloblastoma. It lacks persistent invasiveness. It has a limited tendency for recurrence. So the treatment is basically excision of the lesion. Basically that nodule which is present on the gums can be excised. So in nutshell, intraosseous and extraosseous ameloblastoma are similar histopathologically, and electron microscopic appearances are also similar. They are different clinically only. I hope it's clear. Now we will discuss about the pituitary ameloblastoma, which is also known as craniopharyngioma or Rathke's pouch tumor. It is a neoplasm of central nervous system. It is most common tumor of childhood and adolescence. So basically, there is a Rathke's pouch, which is a precursor of anterior pituitary. So this Rathke's pouch will give an abnormal duct, will give rise to an abnormal duct, that is fetal craniopharyngeal duct. That is a connection between the cranium and the nasopharynx basically. Also, the remnants of these ducts can give rise to pituitary ameloblastoma. Now, the epithelial remnants of this duct are pluripotent in nature. The cell rests are pluripotent in nature and may give rise to tumors which are similar to the ameloblastoma of the jaw. That's why the name pituitary ameloblastoma, right? Now, the clinical features, as it is affecting the pituitary gland, so endocrine disturbances can be seen, or drowsiness and toxic symptoms for depending upon the location of the tumor can be seen. Now, the microscopic features, there is irregular calcified mass present in our brain only, right? And a foci of metaplastic bone or cartilage is seen. It is also compared with calcifying odontogenic cyst because of the presence of ghost cells in the calcified mass only. Several cases of craniopharyngioma with tooth formation are seen. So that's why it is compared with the ameloblastoma of the jaw, right? So I hope it's clear. Now, the radiographic features of ameloblastoma. Ameloblastoma can be multilocular or unilocular. If it is a multilocular cyst-like lesion, it will give rise to soap bubble appearance or honeycomb appearance. So, if the lesion is unilocular, so then no characteristic or pathognomic features are seen. So, here in this picture, you can see a honeycomb or soap bubble appearance. There are septa present in between this lesion. That septa is basically curved, which is a characteristic feature of ameloblastoma. So in this picture you can see it is a unilocular cystic lesion. There is no pathognomic or characteristic feature you can see here. So now the periphery of the lesion can be smooth, or there will be thinning of the cortical plate. Now, the displacement of impacted third molar can also be seen. If the ameloblastoma is of desmoplastic variety, then the anterior mandible is more affected than the posterior one. So, the anterior to molar region is affected in desmoplastic ameloblastoma. So, this desmoplastic ameloblastoma mimics the fibroosseous lesion. There will be areas of radiopacity and areas of radiolucency with ill-defined borders, which will mimic the fibroosseous. We will discuss about the histological features or the histological types of ameloblastoma basically. So there are many types of ameloblastoma, but before studying these types, we will discuss about the diagnostic criteria of ameloblastoma, that is the Vickers and Gorlin criteria. So there should be a tall columnar cells present. The nucleus should be hyperchromatic, means should be dark staining nuclei present. The nucleus should be palisaded, it means the nucleus should be present in a single line only. There should be a reverse polarity of the nucleus. The nucleus should be present away from the basement membrane. So it shows a reverse polarity. Then the subnuclear vacuole formation should be there, as there is a space between the nucleus and the basement membrane. Therefore, the space is covered by some vacuole. So the subnuclear vacuole is formed. In some books, intercellular spacing is also mentioned as a Vickers and Gorlin criteria. So this is all about this diagnostic criteria you should remember. The first type is follicular ameloblastoma, which is the simplest or simple ameloblastoma. So there are two parts that we will discuss. One is the epithelial part and second is the stroma or the connective tissue part. So the first one is odontogenic epithelial cells are arranged in the form of a follicle. So here you can see some follicles present. And the peripheral, at periphery you can see the ameloblastic type of cells, which are tall columnar. There is reverse polarity, you can see hyperchromatic nucleus is there. So these are all the ameloblast type of cells present in the follicular ameloblastoma at the periphery. But at the center you can see a stellate reticulum like cells. So there are stellate reticulum-like cells at the center. Sometimes intrafollicular cyst formation can be seen. So within the follicle, you can see some cyst formation, right? Now the next histological type is acanthomatous ameloblastoma. So there are 2 points that you need to keep in mind. First one is squamous metaplasia and the second one is keratin formation. So the central cells which were of stellate shaped uh, now have transformed into a squamous cells. So here in this picture you can see squamous cells present in the center of the follicle. So basically the follicular type of ameloblastoma has converted into acanthomatous type. So here you can see squamous metaplasia and some of them will show keratin formation in their central part also. In some acanthomatous ameloblastoma, sometimes keratin pearls are also seen, which is indicative of squamous cell carcinoma. So it can mask the squamous cell carcinoma also. There is a hybrid ameloblastoma, which is a different term because sometimes acanthomatous ameloblastoma can be present in a combination with desmoplastic ameloblastoma. That's why the term hybrid ameloblastoma is said, right? Now we will discuss about plexiform ameloblastoma. This is derived from the term plexus, which means network. So there is a network of strands or cords of odontogenic epithelial cells. So these strands or cords are made up of these odontogenic epithelial cells, which are tall columnar in shape or ameloblast-like cells. These cells are arranged in a back-to-back arrangement. In between these cords, we will see stellate reticulum type of cells. The polyhedral or the star-shaped cells are seen in between these cords. Now, the stromal cyst formation is seen in this type of ameloblastoma. What is stroma? Stroma is the connective tissue. So, connective tissue is degenerated in this type of ameloblastoma. Here in this picture, you can see stellate reticulum type of cells bounded in between the strands. The connective tissue is present inside this plexus, right? And the stromal cyst formation is there. The stroma is degenerated in this type of ameloblastoma. Basically, the connective tissue is degenerated. Now, what is the difference between follicular ameloblastoma and plexiform ameloblastoma? So, in first picture, we can see the odontogenic epithelial cells are arranged in the form of follicles. So, these follicles are degenerated in this type of ameloblastoma. So, intrafollicular cysts are seen. Intrafollicular cyst. And the follicles are present within the connective tissue. So this is the connective tissue and all the follicles are present within the stroma or the connective tissue. But in plexiform ameloblastoma, here we can see all the odontogenic epithelial cells which are present in a form of network. So there is a network of odontogenic epithelial cells. Stroma is seen within this network. So this is the connective tissue, this is the stroma which is present within this network. And stroma, basically the connective tissue is degenerated to form a cyst. So stromal cyst is present in plexiform ameloblastoma, right? One more feature, that is the plexiform, the odontogenic epithelial cells, the tall columnar cells or the ameloblast type of cells are arranged in a back-to-back fashion. Now we have read all about follicular, plexiform and acanthomatous subtypes of ameloblastoma. So the follicular type of ameloblastoma is having the highest recurrence rate, which is around 29.5%, whereas acanthomatous type of ameloblastoma has the least recurrence rate, that is 4.5%, and the plexiform subtype of ameloblastoma is having 16.7% of recurrence rate. Now the next form is granular cell ameloblastoma, in which the cytoplasm of the stellate reticulum cells have transformed into a coarse granular eosinophilic material. So here in this picture you can see stellate reticulum cells present at the center, and the cytoplasm has become or has transformed into a coarse or a granular material, and that's why the name granular cell ameloblastoma. Now, what are these granules? These cytoplasmic granules are nothing else but the lysosomal aggregates. Now, why these lysosomal aggregates present inside the cytoplasm of stellate reticulum? So, there are three reasons. The first one is dysfunction of the lysosomal enzyme. The second one is apoptotic cell death due to because some of the neoplastic cells will try to eat up or phagocytose the adjacent neoplastic cells. So that will lead to lysosomal aggregation. And the third reason is transitional phase of the ameloblastoma itself. Now the next form is basal cell type of ameloblastoma, which is the rarest form of ameloblastoma. It resembles the basal cell carcinoma of skin. Now there are two things, peripheral cells and the central cells. So the peripheral cells are cuboidal or less columnar. That's why we call them primitive, and these are arranged in the form of sheets, whereas the central cells are basaloid in shape. So the central cells are basaloid and the peripheral cells are less columnar, right? So here in this picture you can see the basaloid type of central cells are there and peripheral cells are cuboidal in nature. Now we will discuss about the desmoplastic ameloblastoma. It is also a rare subtype. Here the connective tissue or the stroma is dense in nature. Dense collagenous stroma is there which may appear as hyalinized and hypocellular. Due to this dense stroma or dense collagenous stroma, the epithelium will be squeezed and this epithelium will take a shape of thin strands or cords, which will appear like a kite or an animal. So in desmoplastic ameloblastoma, we can see kite-like or animal-like appearance of the odontogenic epithelium. The peripheral cells are flattened or cuboidal and the central cells will be squamoid or spindle in shape. Now here in this picture you can see the dense stroma. Dense stroma will pressurize the odontogenic epithelium or the tumor islands. So these are islands present, tumor islands that are being pressurized by the dense stroma and due to which these islands will take up the shape of kite tail or will have animal-like configuration. This is seen in desmoplastic ameloblastoma, right? Now the next form is hemangiomatous ameloblastoma, which is a less common type. Here in this type, blood-filled spaces are present inside the stroma or the connective tissue. Why these spaces are present? Why blood is filled inside the stroma of hemangiomatous ameloblastoma? Because during the odontogenesis or during the process of tooth formation, basically, the blood vessels are induced. These blood vessels will have abnormal proliferation and this will lead to blood-filled spaces and these blood-filled spaces will result in hemangiomatous ameloblastoma later on. Now the types of ameloblastoma that exhibit keratinization. So the first one is acanthomatous ameloblastoma, we have read earlier. Second one is keratoameloblastoma and the third one is papilliferous keratoameloblastoma. So now we will discuss about the keratoameloblastoma. Here the epithelial cells, the ameloblastic epithelial cells will produce a lot of keratin. That's why the name keratoameloblastoma. There are 4 histological subtypes of keratoameloblastoma. We are supposed to read the names only. Papilliferous type, simple with keratocystic odontogenic tumor, and the last one is complex histology. Now we will discuss about unicystic ameloblastoma, which is a less frequent encountered variant of ameloblastoma. So only 6% of the ameloblastoma will show this type of growth pattern basically. So what is unicystic? Unicystic means a single cyst is present and this cyst is lined by odontogenic epithelium. So it affects the younger population with an average age of 22.1 years. It is associated with impacted teeth. So most common provisional diagnosis is dentigerous cyst, because we know that dentigerous cyst is also associated with impacted tooth. It has reduced incidence of recurrence, plus there is better overall prognosis. So the prognosis is better. The histological features of unicystic ameloblastoma. Firstly, the lining epithelium will follow the Vickers and Gorlin criteria, and there are three types of unicystic ameloblastoma. The first one is luminal, the second one is intraluminal, and the third one is mural type of unicystic ameloblastoma. Now the first one is luminal unicystic ameloblastoma. Normally in a cyst there is outermost epithelium that is lining the central cavity, and the central cavity is basically known as lumen. So in luminal type of unicystic ameloblastoma, the ameloblastomatous changes, the tumorous changes is confined to the lining epithelium. So here you can see the lining epithelium which is showing some of the ameloblastomatous changes. The connective tissue or the stroma is normal in this case. This is luminal unicystic ameloblastoma. Now the next form is intraluminal or plexiform unicystic ameloblastoma. In this, epithelium will show, the lining epithelium basically show nodular proliferation inside the cystic lumen. So here in this picture you can see cystic lumen. So this is a cystic lumen present. A cavity is present in which the epithelium or the lining epithelium will show some proliferation. This proliferation resembles the plexiform pattern. That's why the name plexiform unicystic ameloblastoma. Now the third form is mural unicystic ameloblastoma. Here the connective tissue, here the fibrous connective tissue is invaded by the islands of the epithelium, islands of the ameloblastomatous epithelium basically. Now here in this picture you can see a dense connective tissue present and which is invaded by the islands of the ameloblastomatous epithelium, right? Now the recurrence rate of unicystic ameloblastoma is lower because it is a less aggressive type of lesion. Now the treatment of ameloblastoma. So there should be a complete removal of the neoplasm, because incomplete removal will lead to recurrence. The radical and conservative surgical excision can be done, curettage can be done, radiation therapy can be given, or a combination of both. Surgery and radiation should be given in order to treat the ameloblastoma. So this was all about ameloblastoma. Thanks for